without having fluoroscopy. And so someday I wish I could do that as well. Um, so can you guys, can everyone see my screen?
Yeah. Yeah,
Okay,
it's all good.
great, perfect. So those are my disclosures, nothing relevant to the talk. So I'm sort of speaking about something that's totally opposite of what some of the previous talks were about, which is maximum resource intensiveness, I suppose. Although I imagine there's a world where perhaps a 3D printer is available, but we don't have some of the intraoperative imaging or some of the other expensive technology. So this is not completely irrelevant and perhaps will be interesting to everyone here. So the problem is that, and I'm mostly an upper extremity surgeon, so that's what I'll talk about. And, upper extremity deformity, it's complicated. And, it can be post-traumatic, at least in my practice primarily. And this is, examples like cubitus varus or forearm malunion, missed Montegio fractures are common. And, a lot of it also is just even simple Jerry-J instability after distal radius malunited fracture. And the literature is pretty clear that a lot of this deformity is multiplanar. It's pretty easy to assess two-dimensional deformity, but the rotation in the axial plane in the forearm is very tough. And traditionally, we would correct this using plane X-ray or two-dimensional planning. You have multiple X-ray views. You can template the osteotomy preoperatively, and then confirm the plan using various angle measurements, using X-rays in the operating room. You have to kind of use the contralateral limb. For your template. It's can be difficult to account for rotational deformity. I think this method has a steep learning curve, as I think others have touched on. It is a long time to really figure out how to do this well.